Welcome to COVID's Lasting Impact, Caring for Immigrant, Migrant, and Asylee Patients, a 10-episode mini-series within Migrant Clinician Network's On the Move podcast, a podcast dedicated to providers who work with vulnerable populations, specifically migrant populations. In this mini-series, MCN provides clinical teams, including community healthcare workers and primary care clinicians, with up-to-date information, expert guidance, resources, and relatable case stories for identifying, treating, and managing COVID and long COVID among U.S.-based immigrant, migrant, asylee, and limited English proficient patients in the outpatient setting. MCN is a national nonprofit with extensive experience providing timely, practical solutions at the intersection of vulnerability, migration, and health. Each episode provides clinicians with impactful tools and information for improving the quality of COVID care for vulnerable populations. If you want to hear future conversations on the topic of health justice, be sure to subscribe to the On the Move podcast. For resources mentioned in today's podcast, be sure to click on the link in our episode notes to go to our podcast page at migrantclinician.org/podcasts.
Welcome back, everyone, to another episode of our mini-series, COVID's Lasting Impact, Caring for Immigrant, Migrant, and Asylee Patients. I'm Amy Liebman, and I'm MCN's Chief Program Officer for Workers, Environment, and Climate. And today we're going to be discussing what's happening with COVID-19 and other respiratory infections like RSV and influenza. We'll touch on the JN1 COVID variant and prevention strategies such as vaccines and antiviral treatments. With us today is MCN's Chief Medical Officer, Dr. Laszlo Medeiros. Dr. Laz is responsible for oversight of MCN's clinical activities. He's our subject matter expert and is responsible for topics such as migrant and immigrant health and does a lot of our education around COVID-19. He received his MD and his master's in public health from Tufts University School of Medicine, and he's worked all over the world, including on the Congo-Rwandan border during the 1994 Rwandan genocide. And since 1996, Dr. Laz has worked as a board-certified family physician in both inpatient and outpatient medicine settings. He has served as a frontline clinician at Keystone Health Center, a community health center where he cared for migrant farm workers and their families. From 2001 to 2005, he served as the assistant medical director there, and then he became a hospitalist in South Central Pennsylvania, where he continues to work today. In his role as a hospitalist, he has treated thousands of patients with COVID-19. Welcome, Dr. Laz.
Thank you, Amy, and it's great to be here. I would like to just talk a little bit about our experiences here with patients with COVID. And like you said, Amy, I have worked with the migrants and farm workers in and around South Central Pennsylvania, mostly in the Gettysburg area. And this included the last 4 years where COVID has hit really hard in our communities. And we're only about 4 hours from New York City, and our experiences were not as drastic as New York, but it was quite significant. And I work in a population in Chambersburg, Pennsylvania, about 22,000 people. And at the very beginning of this pandemic, we have about 22 ventilators, and this really means that we had about one ventilator per 1,000 patients in the Chambersburg area when this pandemic began. So it was really challenging for us to anticipate this wave of COVID patients, and especially among our most vulnerable patients, which were, again, the migrant workers who did not always have access to care and who lived in trailers and couldn't really isolate. Since that time, I think our group of hospitalist physicians has worked with and treated over 5,000 COVID patients. Most of them in the last couple of years, thankfully, have recovered and have done well. But those first few years were very, very challenging.
So I guess you want to give us a little snapshot of what you're seeing in Pennsylvania right now, and then maybe comment, is that what you think is happening nationally as well?
Sure, sure. So in South Central Pennsylvania, we have a 260 bed hospital where I've been working for the last many years, both inpatient and outpatient. And in the last year, we have seen COVID become less lethal, but more virulent. So easier to catch. But thankfully, we have not had to intubate and put on ventilators as many patients as we had during those first years before we had a vaccination program started.
Great. So right now, today is January 24th. Um, are you seeing RSV along with
Yeah.
influenza and COVID? What are you seeing when you're going into the hospital right now?
So we do have influenza, RSV, and COVID. Now, some people get two of these three viruses. A few people actually get all three of them. So you can get the tridemic, as you can say, that this is what we're experiencing. Although I think it's important to also mention that the influenza season is not as bad as other influenza seasons.
Would you say it's safe to say that right now what you're seeing is sort of our traditional influenza season, maybe not as bad as has been in past years? You're also seeing RSV, and those are more seasonal. And then on top of these seasonal moments that we're having with these two infectious diseases, we're throwing a new wave of COVID, which isn't
That's
seasonal
right.
on top of that. Is that what you're
Exactly.
seeing?
Yeah, yeah. It is something that I think we could say we have a vaccine for each one of those three. And if you take those, you're much less likely to have to see me in the hospital. I'll be much less likely to have to intubate you and put you on a ventilator in our intensive care unit. And you're much, much more likely, if you're hospitalized, to leave the hospital healthy. And then, in addition, you're much less likely to get long COVID. And if you do, it's much less of a severe form than if you had not gotten vaccinated.
So even though we're seeing maybe as not as much COVID as we've seen in previous waves, does COVID remain one of the leading causes of death?
Yeah, unfortunately, that is still true, and our most vulnerable patients that we see are those over 65 and even more so over 75. Those patients who are most vulnerable should be vaccinated because COVID is still a big killer. I also have patients right now who have chronic lung disease and fibrotic lungs and all sorts of different diseases that hit the lungs. And if they require already at home supplemental oxygen, they're much less likely to tolerate an infection, much less two or even three viral infections on top of that. So those again, people with comorbidities, as we call them, such as lung disease and kidney disease and liver disease, those are the people that become most vulnerable to an attack from a virus because they have less to fight back with, less resistance.
So I was just reading today that about 20% of our adults are up to date on their vaccines. That's really low. And only about 41% of those who are over 65 are getting vaccinated. And then when we look at our nursing home residents, only about 37% are up to date on their vaccines. That seems really low to me. And so should we be concerned about that?
Yeah, I think we should. I think those are numbers that we can certainly improve on. And I think thanks to your help here, I got information just recently on England and then Denmark and other places where, they are doing a better job than we are of vaccinating our elderly. And it's really important, I think, to get those numbers up because again, we don't want to see a lot of people getting sick. And like I said before, our small hospital has 22 ventilators. Once we have everybody on a ventilator, this is just a terrible situation where, if you don't have the vaccine and you get really sick and we're full, I don't know what we can do for you at this point. So best to get vaccinated, best to wear a mask when you're sick and isolate from those who are even more vulnerable than you are. So I know we've just had the holidays in December, Thanksgiving in November, and we did see a spike in cases of COVID, cases of influenza, and cases of RSV. And interestingly, years before this, when we were all masking and we were all using PPEs and all that, the rates of influenza those years, the rates of RSV seem to have gone down significantly as a beneficial side effect of the precautions that we were taking. So we know these precautions actually work, but it's just being able to get the public to adhere to those recommendations. That is the challenge.
So we have some tools. We have an effective vaccine, right? And also that vaccine, it might, not keep us from getting infected, but it's likely to help us stay out of the hospital, and hopefully, and certainly not die. Although, some people have a lot of other comorbidities. But does the vaccine, and simply trying to prevent being infected, is that going to help at all with long COVID?
It should help. Our data coming in now say that the people who've had long COVID, they do much worse if they got COVID because they were not vaccinated. The vaccination kind of dampens down a little bit some of the inflammatory responses that the body has when you have COVID. And so the result of that is that we do have fewer cases of long COVID and they're less intense in general.
So we have this new variant, JN1. Tell us about that and
Yeah.
how our vaccines are working with it.
So JN1 is, I guess, one of the offspring of BA 2.86. And there's a lot of variants that become variants of interest to us. And some of these, like Delta and Omicron in the past, have really changed quite a bit their response. In other words, people who have had Delta can still get Omicron, and people who have Omicron still can get this JN variant. So when there's a great shift in the spike proteins, then we realize that we have to update our vaccinations as well. And luckily, all the vaccines that are available now, the Pfizer, the Moderna, and the Novavax vaccines are all effective against the JN1 variant that just really came to life around last fall. And over the last couple of weeks, we've seen the percentage, it sort of dominates the picture right now. I think it went from like 36% to 65% to somewhere in the 80 percentile now of the COVID virus that we are seeing.
I want to take you back to the vaccines for just a second because you mentioned our up, basically in the fall we got this new and improved vaccine, and we can still and that I'm really pleased to say that you're telling us that this new vaccine remains effective against the latest variant, the JN1 variant. And you mentioned that there's, our Moderna and Pfizer vaccines, which are great. And then you mentioned this new vaccine, Novavax. Do you want to just tell us a little bit about that?
Yeah, so Novavax is a protein based with an adjuvant that helps stimulate the immune system. It's monovalent, and we don't have the bivalent vaccines anymore. So it's targeting now the latest variants that we have. It is quite good.
Yeah.
Moderna and Pfizer are both mRNA vaccines. The Novavax is not. I think if you've had side effects from the other vaccines, this may be the one for you. I know people are frustrated that, a tetanus booster you get once every 10 years, an MMR vaccine you get for your kids, and it's like 2 times, 3 times, and you're done. And this one, we're going to have to do more work, and we're going to have to take more vaccines than we thought. But here we had the influenza vaccine for a while, and we just got used to the fact that we have influenza and it changes. Its outer surface proteins change, and this is how some viruses behave. So we're
Yeah.
trying to work with the best science we have.
Absolutely. I still remember the miracle of these vaccines and then crying when I knew that my 80-something-year-old mother could get her vaccine. That was just an incredible scientific breakthrough there. So vaccines are really important tools. They help prevent severe disease and hospitalization and death. We may still get infected, but we're not going to be as sick. What else can we do to protect ourselves from getting COVID-19?
So again, if you are around patients who are sick, like I am in the hospital, I always wear a mask. It's best to wear masks in public. If you have a somebody who's sick, you want to protect them from getting something that you brought in, and you also want to protect yourself from other people around you. Hand washing and social distancing are still very good. If you feel like you're getting sick, it's best to try to get a home test and test yourself. If you feel like you've been exposed, I'd at that point, as per the CDC recommendations right now, for the next 5 days, wear a mask and test yourself. After those 5 days, if you're still testing negative, still wear a mask, but you're more likely not to be sick at that point. But I'd test again at 10 days and then see if you're ready to, at that point, if you're not sick, that's great. If you test positive and you're symptomatic, then it's time to really stay away from the public and stay away from, your grandma who might be
Right.
sick. So an N95 mask is the best. We call those respirator rather than the surgical masks. I wear those in the hospital, but I have the benefit of working in a hospital where we do wear those masks all the time when there's any respiratory virus right now.
Okay.
Yeah.
Yeah, that's so great. So I just wanted a little commercial break here, like letting people know that at the MCN website, we have a lot of resources on a number of things that you just touched on. What to do if you've been exposed. We have information about getting a test. So please visit our COVID hub. There's a lot of really great up-to-date information there. One last thing I just want to touch on, because it's still COVID. We're still dealing with it, but we learned about the airborne aspect of this disease early on. And so can you just let us know if you still think ventilation and airflow is important to preventing
Yes.
COVID-19?
I think as you assess your risk in any public situation, you have to ask yourself, is this a well ventilated area? Is it open? I mean, right now for the Pennsylvania winter, everything is closed. So if you're in a closed environment, how long are you going to stay there? How densely populated this is? This a crowded arena of people? And are they sick, or is anybody, obviously ill? And again, if you're spending a lot of time and it's not ventilated and you're not wearing a mask, you're increasing your risk. It's kind of a progression of risk that you have to take into account.
And so, we've talked a lot about we have these tools of prevention, right? Limiting our exposure, getting vaccinated, wearing masks, thinking about ventilation. So, if we do get sick, what about these new antiviral treatments that are available? What is your recommendation
Yeah.
there?
So there again, it has been an interesting journey through all sorts of different antivirals that we've had. The one winner that seems to have been effective and continues to be effective is the Paxlovid, the nimtrilivir with ritonavir combination. It's one pill. It's usually 300 milligrams of the one and 100 milligrams of the other combined in one pill that you take twice a day for 5 days. And it has been a winner. It has really helped reduce symptoms when symptoms are at the very beginning. Usually in the first 5 days, some people say up to 7 days, but 5 days into your exposure, and you're starting to feel a bit sick, but you don't need to be hospitalized yet. So Paxlovid is one of the great winners, and I'm still using all that. Others have come and gone, but that was one of the best. Another one is remdesivir. This one is an IV intravenous medication, and we give 200 milligrams of that the first day, and then we give 100 milligrams for the next 4 days. It's usually 5 days in the hospital. There are outpatient centers where people are not so sick that they need to be hospitalized, but they're fortunate enough to have an infusion center in their location. You can give this to them in 3 days, but it is an IV. And so you go back for 3 days in a row and get the remdesivir. So if they've started that and they got sick enough to come into the hospital, I'll often add 2 more days to make it 5 days. And if they're in the intensive care unit, in the past, we've given up to 10 days of remdesivir if they're intubated and sick enough, because when you're intubated, you can't take the Paxlovid really, and nor should you, because you're past the
Right,
usefulness of that. And then there's molnupiravir, which is another medication that is out there. It's 800 milligrams twice a day, also for 5 days. And sometimes that is better for certain populations for whom the Paxlovid is not the best medication for other comorbidities that they may have. So I know a lot of doctors are hesitant to give Paxlovid because our elderly population are the ones who need anticoagulants like apixaban, for example, or cholesterol-lowering medicines like the statins. And these medications are not compatible with Paxlovid. So sometimes our doctors are hesitant to give those medication, Paxlovid, to people who need these other um, medications to survive. So it becomes a little trickier. And but the way I practice, I would stop a cholesterol lowering medicine for 5 days and give the Paxlovid because the risk benefit ratio weighs heavily on giving the Paxlovid and stopping the statin for 5 days. That would be my recommendation. That's what I do with my patients. The other medicines, the anticoagulants, might be a little trickier, and maybe the molnupiravir is a better medication for those situations. And then also for some patients who have behavioral health issues and take medications for that, that's really challenging sometimes because you have to come off those medicines and you often need to taper off those medicines. But the Paxlovid, you have that 5 day window, and by the time you get to taper off those medicines, they may not be, effective with the Paxlovid. So for those people, the molnupiravir is a better medication.
It sounds like it's an important tool that can save thousands of lives. So help us understand a little bit. You're really recommending these antiviral treatments. They're a really important tool in our toolbox. They save thousands of lives. Should we be concerned about this rebound, or what's tell us a little bit
Yeah.
about that?
So the rebound is a real effect, and it does seem to happen up to like 1 in 5. So about 20% of cases, they have some kind of rebound. Not all of it is a very severe rebound, and many people just have a very mild rebound at that time. Now, if that happens, you start to feel a little bit sick again, and you're kind of disappointed that you're sick and it's just kind of lasting a little bit longer. You should not take another dose of Paxlovid or molnupiravir or anything else at that point. Usually something like a little Tylenol or something like that to get you through is the best thing to do there. But I still feel like the benefit of the Paxlovid is that you get less of an intense uh, breakout of COVID, and that will also be beneficial down the road if you're considering long COVID, because if you have this rebound, it is challenging to some people. But having taken the Paxlovid, you're still giving yourself a huge benefit down the road. So I would still say it's much better to say I'll take the medicine rather than saying, well, there might be a 20% rebound, but 80% of people don't have the rebound, and you have a huge amount of benefit from that situation.
Yep. Well, that has been so helpful. You gave us so much information to think about. COVID's still out there. We need to remember that we have a lot of tools available to us. We've got the vaccines. We have 3 options for vaccines. We also have some of our old tools. Our N95 respirators can really make a difference. And we know that ventilation and thinking about sort of the space that we're in as we assess our risk is really important. You also talked a lot about the fact that our elderly and are still the ones that are most at risk, which hopefully is a motivator for all of us to think about those who are at risk from still getting very sick or dying from this disease. And so those vaccines are going to make a huge difference in that. And then should we get sick, we've got antivirals available to us. We have a lot of tools that we just did not
Right.
have in March 2020, right?
Yeah, I think
It's
we've come
pretty
a long
amazing.
way, and we've dropped some of the things that didn't quite work, like the convalescent plasma. We thought that was a good idea. It sounded good, but we have to follow the science. And I understand for people it's confusing because you're recommending something at one point and you're not recommending that, and you're going to something else later. We'd have to follow the science and see what works. And so when the evidence points to something not working, well, then we'll change course here. One of the other things I want to mention, I don't think we talked much about pediatrics. These vaccines are good for even younger children, and so I would say please get your children vaccinated. I know we focused a lot on the elderly here, but I really do feel I think both Moderna and Pfizer are for 12 years and older, and the Emergency Use Act has also allowed that to go down to 6 months of age and above. So at this point, 6 months to 11 years is okay for the vaccines of Moderna and Pfizer at this point.
That's a really important point to end on, that even though we're looking at these really different kinds of death rate, getting sick is not fun at all. And having your kid hospitalized because they're sick is really not fun. And you don't want to see them in the hospital. So particularly when we have
Yeah,
all these tools available to us.
right.
I just wanted to make first of all, I want to thank you so much for your information. It was incredible. And also always so grateful to you for the work that you're doing on the front lines in the hospital. It's been, not only are you saving lives, but you're taking that information and you're bringing it back to Migrant Clinicians Network and helping us really understand this disease and what we need to do to prevent it. I do want to remind folks that we have a lot of resources on almost every single topic that we talked about today in our podcast. It's on our website at migrantclinician.org at our COVID hub. And we also have a frequently asked question award-winning blog that Dr. Laz and our writer Claire Hutkins-Seda and MCN staff contribute to. So there's all these resources for you at MCN. And I want to thank all of our podcast listeners for joining us today. And I always love talking to you, Dr. Laz. I do want to let folks know that we have another upcoming webinar as part of our Pfizer series. That will be on Thursday, February 29th. MCN will be hosting a webinar with the National Hispanic Medical Association featuring Dr. Eric Russell, who will be speaking about COVID and pediatric patients. So you gave us a nice little segue into that webinar, Dr. Laz.
But I also want to thank you and our podcast team here, because you guys make it look so easy. There's a lot of hard work that goes behind this. And I think we have a really deep bench. So I feel really honored to work with MCN. And you guys always point me in the right direction if I'm looking for something I haven't quite found yet. In trusted leaders in public health. And I think that's really important because there's so much misinformation and disinformation out there. I'm really glad to be able to work as a physician, right, with a COVID population that needs medical care, and also working with MCN to bring that message out and work with our vulnerable populations in across the United States and globally.
Great. Thanks, Dr. Laz, and thanks to our podcast listeners. And I mentioned our website, but you're also free to connect with MCN on LinkedIn, Facebook, and X or
Twitter.
Twitter. Yeah. We're getting information out to you both in English and Spanish in all sorts of ways. So please take advantage of those resources. Thanks so much.
Thank you.
To access resources mentioned in today's podcast, click on the link in our notes section to go to our podcast page at migrantclinician.org/podcasts. Visit migrantclinician.org/sign up to join our email list and subscribe to our blog to get updates on new MCN podcasts, resources, and webinars. Migrant Clinicians Network is a national nonprofit dedicated to providing practical solutions at the intersection of vulnerability, migration, and health. We offer technical assistance, health provider capacity building, resource development, research and data and evaluation support, and virtual case management for mobile populations, and free resources and training. The information in this podcast is for trained healthcare professional education only. Information should only be used in combination with up-to-date national and international guidelines. The information is not to be used as healthcare advice for the general public.